first presenter is Dr. Majid Al-Aboud kindly accepted our invitation. Majid at the moment is a consultant endocrinologist who is practicing in Basra, Iraq. So we're very delighted to have him with us. Majid finished in the University of Kufa in terms of his graduation and high diploma in internal medicine. He's also had a postgraduate degree from Macquarie University in Sydney during his scholarship when he came. Very eminent and prominent endocrinologist in Basra, has been the head and the in charge on the African Congress, Middle East and North African Congress of Obesity in Iraq. And he has many published papers. He's in charge of training on different levels. Dr. Majid Al-Aboud has kindly accepted to talk to us about the medical management of obesity, inclusive of interaction, possibly metabolic syndrome. Go ahead, Dr. Majid, please.
Thank you, Dr. Mohamed, for the nice introduction. Can you let me to share my screen because it says the host disabled participant screen sharing?
Yep, absolutely. So I'll make you able. Yeah.
طبعا.
All right. It should be okay. Share it now.
Okay. أشكر زملائي الأعزاء تحوا لهذه الفرصة العظيمة التقي بحضراتكم وفي هذا اليوم إن شاء الله. My colleagues in Sydney, I've been in Australia before, and I always miss Sydney and Australia, of course. So my presentation today, can you see the presentation? Is it okay now?
Yes, indeed. Yes, all good. Go ahead, please.
Okay. Before I will start talking about my subject, which is medical of obesity, we should know what obesity is. As you know, obesity is defined as a BMI of equal or more than 30. And simply, we can get our BMI by dividing our body weight in kilograms by our height in square meter, and we'll get the number. And obesity has been recognized as a chronic disease rather than a risk factor for other diseases by many societies since 7 years, such as the World Obesity Federation and the FDA of America. Epidemic of obesity, as you can see here, this is the world map of obesity. The darker the color means the higher the prevalence of obesity in a given country. And it is very obvious, it seems that Australia and Iraq share this prevalence of obesity, which is very high compared to the rest of the world. If we have a closer look on the figures from Australia, it has been estimated that 35% of Australian adults, they are obese, and the prevalence of obesity more than doubled from 1980 to 2000. The story is much the same in Iraq. Iraq is not doing any better more than Australia, and it is estimated that more than 2/3 of Iraqi adults are either overweight or obese, according to the WHO stepwise survey that was conducted in 2009. And actually, now we are expecting these numbers are even more. The pathophysiology of obesity is complicated and multifactorial, but in general, we are living in a homeostasis between energy expenditure and energy intake. If we increase our energy intake and reduce our expenditure, of course, we'll end up with obesity. In addition to that, there are genetic factors, epigenetic factor play a role. The hormone leptin, which is the good hormone that induces satiety, plays a role. Other hormones from the gut also play a role, and the myokines and other environmental factors, medications, and very importantly is what is called the hedonic input. Whenever we feel sad or depressed, usually we go for eating because eating will induce some sort of happiness in the human being. This is called the hedonic input. And the problem is that the high energy, the poor quality food is usually palatable and it is cheap. On the other side, the good food, the healthy food usually is less palatable and usually expensive. And as you know, obesity factor for a number such as type 2 diabetes, osteoarthritis, cancer, and many others. And not just the effect of obesity is on the other diseases, but obesity will reduce the life expectancy. For example, if somebody has got BMI of more than 40, then that one will have a chance of reaching 70 years only 50%. So obesity will affect the life expectancy, of course. Weight loss is very important, and if we lose as minimum as 5 to 10% of our body weight, we will get benefit on many organ systems and conditions. We will have a reduction in the risk of type 2 diabetes. We will have a risk in the reduction in the risk of cardiovascular disease, hypertension, hyperlipidemia, sleep apnea, and the overall quality of life, of course, will improve. And if we have a look on the guidelines on the management of obesity, then we should consider medical treatment of obesity whenever the BMI is above 30, or if the BMI is equal or above 27 with comorbidity. And by comorbidity, we mean hypertension, diabetes, dyslipidemia, obstructive sleep apnea. And of course, the fundamental to all obesity management is lifestyle, including diet, exercise, and behavioral medication. And of course, Professor Ahmed Rubai will talk about, and Dr. Muhannad will talk about the bariatric surgery later on. So let's have a look on the first treatment approach, which is behavior and diet. This consists of three pillars. The first one is the nutrition, second is physical activity, and finally is the eating behavior and psychological aspects. In general, we have to accept steady incremental progress toward our goal, and we have to be realistic with accept a 5 to 10% of body weight to be lost during the first 6 months. In the interim period, we should maintain this weight loss, and we should check with each time we see our patient. And this is the hierarchy of physical activity. Our physical inactivity should be limited. For example, sitting watching the TV to the minimum. We should do muscle exercises in the form of weight-bearing exercise 2 to 3 times per week. Ordinary daily activity should be done every day, and of course, the cardio should be done 5 times a week at least. Now, what about the pharmacotherapy, the medical treatment of obesity, which is the second line of treatment after the lifestyle changes? Up to date, there are several medications that are approved for the treatment of obesity in Europe and in the United States. This includes Orlistat, phentermine, the combination of phentermine and topiramate, which is called Zymia, and the lorcaserin, in addition to the combination of naltrexone and paprobion. This is called Contraindications, and we have the Saxenda, the Raglutide, and finally Ibutramine. Ibutramine is approved by the FDA. Start the naltrexone and paprobion combination and Saxenda. But in February last year, lorcaserin was withdrawn by the FDA because of some report of cancer. So lorcaserin is not used anymore in the United States nowadays. In the following slides, I'm going to show you the evidence behind the benefit of these medication in short. So Orlistat is one of the oldest medication, as you can see here, compared to placebo. People who were on Orlistat at the end of first year of the trial, they got around minus 10.2% body weight loss. The same story has been seen with the scale trial of Saxenda, the liraglutide. As you know, liraglutide is a GLP-1 receptor agonist, a glucagon-like peptide-1 receptor agonist. It induces satiety and it decreases gastric motility. At the end of the first year of the trial, again, around 10% body loss was achieved. So it is similar to Orlistat. The same thing is applied to naltrexone paprobion combination, around 11.5% of body weight loss was achieved at the end of the first year. And in the sequel trial of the effect of phentermine and topiramate, as you can see here, those on maximum dose of these medications, they got around 10.5% weight loss at the end of the trial, at the end of the first year of the trial. So if we put all of these medications together and compare the efficacy after we eliminate the effect of a placebo, of course, we can see that the combination of phentermine and topiramate, which is called the Xymia, is the most potent medication for obesity, followed by phentermine alone, then the combination of naltrexone and bupropion, the Contrave, and then the Saxenda, the liraglutide, and the weakest among all of them is the orlistat, the Zeneca. Of course, these medications don't come without side effects. For example, the orlistat, because its mechanism of action, which is a lipase inhibitor, we expect that it will cause flatulence, fecal urgency, sometimes staturia. For the liraglutide, the Saxenda, it causes usually GI side effects like nausea, hypoglycemia, diarrhea, constipation, vomiting, and sometimes headache. And finally, for the naltrexone and bupropion combination, because this medication acts in the central nervous system, these side effects are expected to be from there, such as nausea, headache, vomiting, dizziness, insomnia sometimes, and the dry mouth. And the problem is not only with the phase of losing body weight. Actually, losing weight is easy, but what is more difficult is to maintain what we've lost of our body weight. In the phase one, as you can see here, most people lose a good amount of their body weight, but the problem later on, they regain most of the lost weight. Again, in this trial, you can see over 8 years, majority of people who lost weight at the beginning, they regain what they've lost from their body weight. That's why obesity now is considered as a chronic relapsing remitting disease. It is a chronic disease, incurable, unless we do certain procedure like surgery. Why is that? Because whenever we attempt to reduce our body weight, the body will resist that. And the hormones that are responsible for feeling of satiety, like the peptide, YY, the CCK, the amylin, the leptin, will go down. On the contrary, the hormone that is responsible for feeling of hunger, the ghrelin, will go up. So it is the problem with the perception of our mind, where the reality, we are living with a lot of food beside us, but our brain is perceiving that as if we are living in a famine. The armamentarium of obesity is growing, and now there are new avenues for pharmacological targeting, and there are many ongoing trials on different levels and different phases. For example, there is a new medication called setmelanotide that underwent phase 3 and passed the phase 3 trial successfully. Hopefully will be approved by FDA this year. And the setmelanotide is a melanocortin 4 receptor agonist. And in this graph, you can see the history, the journey of the medical treatment of obesity compared with bariatric surgery. At the top of the graph, the green color is the bariatric surgery. Up to date, so far, bariatric surgery is the best and the most powerful intervention for treatment of obesity. And fortunately, over the last couple of years, we have medications with increasing efficacy and potency, and almost we are approaching by medical treatment bariatric surgery, hopefully over the next 5 years. However, despite all of these data, we have treatment gaps. So if you remember, I told you that according to the guidelines, we need to treat obesity by medical treatment whenever we have a BMI of 27 with comorbidity or more than 30 without comorbidity. So according to these figures, in the United States, there is 116 million adults who fit the criteria for medical treatment. But look, who are receiving the treatment? Only 2% of the American population who fit the criteria for medical treatment of obesity, they are receiving obesity. And if we compare those who are receiving treatment for obesity to those who are receiving treatment for diabetes mellitus, for instance, the difference is very clear. So on the left side of your screen, you can see only 2% of adult people who need the treatment, they receive treatment, compared to majority of people with type 2 diabetes, they receive their medication. So in summary, obesity is a highly prevalent chronic condition that needs to be considered as a disease. And obesity manifests as a number of cardiometabolic and other conditions. It can lead to many complications like cancer, osteoarthritis, sleep apnea, and it will result in dysregulation of a number of hormones that will resist the process of weight loss. That is why it's true that it is difficult to lose excess weight, but perhaps it is even more difficult to maintain what we have lost of our body weight. But what is good is that we have increasing number of medication that can be used for the treatment of obesity. And thank you very much.
Thank you very much, Dr. Majid. Very refreshing presentation and such a good start of that evening. As housekeeping issues, perhaps I suggest we collect all the questions until the end, because we might overlap in the information provided, etc. Then we'll try our best to finish as early as we can, so we can provide as large as a gap for questionnaires. If Dr. Ahmed is still with us, yes, all right. So I am perhaps now keen to start my part, and if I would ask if everyone can see my presentation.
Yes, we can now.
Perfect. All right. So I am starting soon. All right. So this part, I'll do my best to finish it in 15, 17 minutes. And contrary to the endless talk on calories, measurements of calories, etc., today we'll try to change the talk to be about hormones rather than calories, and whether that makes sense to our medical management or preoperative assessment and even postoperative follow-up on patients. So it is the eating styles, and then we will end up showing a few things about intermittent fasting. So I have a disclaimer before I start that I rarely consult dietitians for our patients, and I have some reasons for that. And I perhaps think twice before I consult an endocrinologist. So the second point, that a human is an omnivorous creature which eats herbivores and some herbs, and of course conditions apply. Those people who are vegetarians or vegans, I'm not sure about that, but as if you're taking a charter flight with unpredictable landing. Once again, our culture and eating styles, I do remember when I was a kid that our families were feeding us 3 meals a day. And if you ask mom about something in the afternoon, she will say no, because that will ruin your dinner. And if you ask for something to eat before you sleep, she will say no again, because she will say you could have eaten more at dinner time, and your body need to process and absorb what you have eaten in dinner. And guess what? If you are naughty against one of your brothers or sisters, you will be sent to bed with no dinner. And it happened that none of us has died. So I could not criticize this policy at all. And in fact, we're teaching this policy as we speak. The body does not calculate calories. There is nothing called calorie receptors at all in the body. Why do we calculate calories? All the rest of all of what happened for the last 50 years of accusing the fat as a causative agent of multiple diseases has given people a fat phobia. And of course, to chase an alternative calorie source, then people have consumed lots of carbohydrates, and that is the problem. All the rest are myths in terms of calories in should equal calories out, etc. If you review all the dietary plans that is all over, well known all over the world, Aitken diet, paleo, although I find it hard to call it a diet, ketogenic diet, the Japanese diet, the French diet, all of them have one factor that they share in common, which is they lack the sugar. So as if that make us feel that sugar is the bitter factor actually that leads to the problem. And low-fat diet is clearly in this equation a real myth. So by sugar, we don't only consider the white simple sugar, which is a true mistake, but we consider all the simple carbohydrate. May I kindly ask whoever is not talking perhaps to mute, so because we're recording on the iCloud. Now, quickly, I wouldn't spend lots of time on comparison between white bread, beer, and, for example, fructose as a liver response. But we do know that the liver has a policy for every single agent to deal with. And the liver is not a hotel, actually. So the liver has very minimal room to store anything in, except some glycogen as per default. For that reason, beer, for example, wins the triage when it comes to the liver because it's a toxin. So the liver will take all of that to process it, to detoxify, and that will result in all of the unwanted toxic event. In addition to the fact that what we said, that the liver is not a hotel. So a amount of that beer. So that's what we call the beer belly, as most of that will be converted to fat and stored perhaps the abdominal wall. White bread on the other side has less, although it's harmful, it has less effect because perhaps the minority of it will be converted to fat. However, if you consider the sugar fructose, for example, which comprises all the unwanted sugars in our life, there is no single policy in the liver to digest the sugar fructose. And that makes all of that, most of it, will be converted eventually to fat after it exits the Krebs cycle, especially the very low density lipoprotein. And that's what we call the sugar belly. So in the end, it is so clear that anything that contains carbohydrate is a problem. And that would take us to the ketogenic diet versus the Aitken diet, why the fat came, trying to prove that it was just malreputed rather than anything else. And it is a robust premium source of fuel, as 1 gram of fat would give you 9 calories. The ketogenic diet is used, and we found it effective here as it answers the question and also has additional effect. It's not only a diet that is very low in carbohydrate, but more difficultly is a diet that is abundant in fat. And I found it actually too difficult to allow myself to eat 75% of my calories as fat. It is hard, but at least the majority of the components has to be fat, with an aim to prime the system to educate the mitochondria to use fat as a source of energy rather than the default glucose. And that would eventually, over a few weeks, lead to mitochondrial adaptation. It spares muscle mass and it reduces body fat for sure. It gives a fascinating cognitive function, and by history it was first used in those patients with epilepsy. It is successfully used in type 2 diabetes, although in caution with type 1 diabetes. And as I mentioned, in 6 weeks' time, the mitochondria would learn to use the ketones instead of glucose as a source of energy, and that is very useful, and it's a premium source of energy. Not to spend a long time on this slide, but perhaps people are always asking, how about dairy products? How about milk itself, for example? And I want to mention that, first of all, the adult cow does not drink milk. Why do we? Secondly, it's a significant paradox. You send those people to the dietitian, they give them skim milk. And I can see that any cow has too many photos of a prime minister, for example, in the market, and still we're skimming her milk, ruining her good job. This is very rude, I guess. I would like to remove the milk altogether. And then people will start asking, how about calcium, osteoporosis? What do you want us to do? What's wrong with cheese? The bacteria has worked beautifully on the cheese, sucking all the sugar and modifying the protein chain, made it less allergenic and very useful to you, composed of fat and protein. And cream is the best, but provided you don't eat it with the bread. Butter is a premium. However, it's a disclaimer that people always eat it with bread. Sweeteners, are they good or bad? i.e., can I drink Coke Zero, for example? And our take of that, there is an unmeasured risk here. The FDA has failed, perhaps purposefully, to do or provide any research so far. There is an anecdotal evidence that it blunts the taste buds. And certainly my answer to the patients that Coke Zero, for example, although might not raise your blood sugar, but certainly would stimulate the insulin. So it is not an insulin neutral. So that would take me to a statement that in all of our attempt here that we need to lower the insulin by all means. Oils, etc., although we encourage fat, but we have to be careful about the cooking oil as it's more richer in omega-6 compared to omega-3. And we know that those two types of omega compete on the receptors. So omega-3 is anti-inflammatory, which we wanted, but omega-6 is pro-inflammatory. So perhaps loss of cooking oil is not good. Vegetable oil is totally unsupported. Vegetables to be eaten, not to be squeezed for oil. And as the fat is innocent, we need to stop leaning the meat when we buy it. That is, once again, one of the acquired wrong habits, but God has surrounded the meat for you with a layer of fat for you to enjoy. Now, I would like to talk a little bit more about the insulin hormone itself. It is simply a cargo. So the insulin has one function, is to take the glucose from bloodstream and distribute it to the cells. That's why we, under the effect of civilization, that we have been eating much more than we needed until we became ingrained into those kind of foods became ingrained into us. So, however, we know that the body is not stupid. Actually, our human body is very smart. Whenever there is extra, they store it, and to be used in times of fasting. Very simple. So if we continue eating high carbohydrate and frequent meals, for example, and frequent snack, then the insulin will be unrested. It will be ongoingly stimulated nonstop. And with a function coming to it from the main office to send sugar to the cells. However, we know that the cells have certain quota and they cannot accept more sugar than they can every day. And then the insulin fails at this stage to do the job. But then the insulin will receive another order to increase the quota of the cells over census, hopefully they receive more and more sugar. That would result in cramming and squeezing more sugar in the cells. Guess what? The cells will start to hate the insulin. And it is a hate relation, disrespect and animosity that will develop then between the cells and the insulin. That's what we call insulin resistance, actually. And when the insulin goes nowhere in doing its job, the next step is to store some as a glycogen with a limited capacity, and also to convert to fat. And that is the problem. So it is the cargo guy now has become the belly maker guy. So in thinking, we should always think about reducing the insulin as an attempt to help those people reducing the resistance. And that is actually our disagreement with, for example, some of our gynecology colleagues. As if you check the American Association and even Diabetes Australia, they believe that type 2 diabetes is a chronic and progressive disease, which we totally disagree with. It's a curable dietary disease. And they also believe that the goal of the treatment is to control blood sugar. That's why all the agents are against blood sugar reduce. This is innocent. The goal of treatment is actually to reduce insulin resistance. There is no point to reduce the blood sugar. Making the insulin even higher, increasing the insulin resistance does not make any sense to me. As if hiding the trash under the bed will only make the room more smelly rather than helping the problem. And it is even leaflet of those glucophage and other hypoglycemic agents that you need to eat more frequent meals and carbs because you're taking medication. And to me, this is a recipe for failure. When instead we believe snacking is a crime and low carbohydrate diet and stopping snacking and intermittent fasting is the way to go. And they believe that weight loss will improve diabetes, which we totally disagree with. We have our own body of literature to show that weight loss has no effect on diabetes. But actually, it is the persistence on the low carbohydrate diet and the abstinence from the snacking and intermittent fasting that will definitely reduce the blood sugar, improve insulin resistance, and perhaps cure diabetes. So in summary about that stop snacking. Snacking is a crime. Adopt low carbohydrate diet and think about intermittent fasting, which is coming. So intermittent fasting is a way that is certainly under practiced by a good number of the patients and perhaps not supported by a good number of the colleagues. However, it's not a science that came yesterday. It has been there for years and years. And we know that the body can be trained to fast. And we know from different religions that fasting is a crucial thing. And we know من الموروث العربي مالتنا أنه صوموا تصحوا تناول الطعام فوق الطعام مفسدة. يعني those sentences are very, very known to all of us. It is different from starvation. It is a voluntary, complete withholding of eating food while maintaining fluid status. What fluids? Any fluid like water, coffee, or tea with no sugar or milk. Keep yourself hydrated, no problem. If you drink black coffee, that will reduce your appetite, helps you, but it will not breach your intermittent fasting. It's an enhancement of ketogenic diet, and actually ketogenic diet would enhance your fasting performance too. It's flexible, free, easy to understand. You can add it to any diet you like. So I'm not actually sort of promoting ketogenic diet, but the ketogenic diet is the best that plays with intermittent fasting. It gives you an unlimited power because it's actually 0 calories if you compare it to a low-calorie diet. And you cannot, for example, do more vegetarian than you're doing. You cannot do more low-calorie than you're doing, but 0 calories, of course, is better. It gives you an astonishing mental clarity as the sympathetic tone is up. It's good for students to study, contrary to the belief that you need to eat and study. It does not burn muscle mass as the growth hormone goes up, which is a muscle sparer and fat burner. It's activate autophagy and offset oncogenic effect of fat. That's by itself sort of a different subject. Growth hormone in intermittent fasting goes up. tremendously. It lasted for hours and hours. What does it do? It mobilizes your fat, but it spares your muscles for you. And it offsets the effect of ghrelin hormone. By the way, ghrelin hormone is the timid boy, actually. So it's the effect of ghrelin hormone only lasts a couple of hours. And all of us have noticed, for example, when we become very hungry, however, we don't have access to the food and we're so busy, in 2 hours' time, the hunger will disappear because the ghrelin hormone of hunger has dropped down. The half-life of ghrelin hormone is around 10 minutes, but the total effect is around a couple of hours. So if you feel hungry in the evening, there is no problem with that. Just sit tight and wait. And in 2 hours, everything will disappear. So the intermittent fasting is certainly better than snacking with calorie restriction, because it turns the body into ketosis, which is the target. However, low calories will never fully turn on ketosis, and ketosis causes fat loss, whereas the fat is lost in calorie restriction type, but refeeding syndrome is very high. Ghrelin hormone will never go down with multiple snacking and low calories, because you're inducing the insulin, which will go up and down. Then you feel hungry, then the ghrelin will go up, etc. The growth hormone increase, we know that intermittent fasting with all of the above effects. And the metabolic rate is only decreased a little bit with intermittent fasting, because it's offset by the counter-regulatory hormones, the adrenaline up, whereas the metabolic rate goes down in calorie restriction as the body goes into the budget mode. So our advice, as the last slide, actually what we're recommending, that you fast for at least 14 hours a day. So you can start with 12, and then they increase yourself to 14 hours. And I would like to say the fasting has 3 phases, and the eating window has 3 phases too. The first phase of the fasting will perhaps start from 7 p.m. to 11 p.m. where you're about to sleep. And at that time, I really want my patient to be as active as possible, doing physical activity, mental activity, checking their computers, cleaning, etc., because that would help them to digest whatever simple sugar they had in the last meal. Then you sleep for a good 7-8 hours. That will certainly induce fat metabolism, as the body would consume lots of energy during sleep. But remember, the sleep is associated with S and S. So the bed for sex and sleep. There's nothing else. It is a wrong behavior to grab, for example, a social advice and deal with others, because that will increase your concentration and stress and make your sleep interrupted, defeating the purpose. Then you would wake up at 6 or 7 a.m., for example. And who said you need a breakfast immediately? Breakfast by language to break your fasting. No one said it has to be at 7 or 8 a.m. It can well wait till 10 or 11 a.m. So the more you stretch your breakfast, the better, and more preferably if you can do some exercise. Then your eating window starts, which is 2 to 3 meals over some 8 hours or 10 hours. And once again, there are 3 meals, good real food. So you would eat to fullness real food, and no simple sugar or simple carbohydrate. And once again, you eat a breakfast, nothing until lunch, then eat a lunch, then nothing until dinner. And if you need a piece of fruit, you'll take it with dinner combined, but not otherwise. Perhaps I'll skip that. And physical therapy, always with low intensity exercise rather than high intensity. Any huffing and puffing is not good to lose weight. To walk or to run, certainly to walk, and walking better than running. And perhaps I'll stop here as a summary of that, my first part. And I apologize if it took perhaps 20 minutes, but very keen to introduce our colleague, Dr. Ahmed Rubai, to start the third part. Dr. Ahmed Rubai does not need any introduction. He's perhaps our most senior gastroenterologist. He's a therapeutic endoscopist and a bariatric endoscopist. He teaches and trains different levels, from fellows, advanced trainees, basic trainees, and students in University of New South Wales. He finished his training in Westmead Hospital. Then he had 2 subspecialties in Japan and Spain. If Dr. Ahmed is with us, Dr. Ahmed, you are muted. I have sent you a request to unmute, and hopefully you can start your part. Dr. Ahmed, can you hear me?
Yeah, can you hear me, Dr. Mohammed?
I can hear you very well.
Can I share the screen?
I have introduced you already, but maybe you were muted.
No. Can I share the screen just if you?
Of course, I will just take that down and yeah.
Is the screen shared?
No, 1 second, Dr. Ahmed. Just give me 1 second. It says multiple windows open.
Yes, Dr. Ahmed, we are seeing your screen very clear.
Okay.
Go ahead, Dr. Ahmed.
Go ahead. Yep. Thank you very much, Dr. Mohammed. Let me first start with welcoming again our colleague, Dr. Majid Al-Aboudi. It's actually prevalent and pleasure for us to have him on this webinar, both on academic, medical, and scientific level, and also for me on emotional level. احنا يعني مشتاقين موت للعراق، فمن نجي نسمع زميلنا من البصره بالتحديد فيزداد هذا الاشتياق. فاهلا وسهلا بك. انا اليوم البرزنتيشن مالتي راح تكون على it's about the endoscopic bariatric therapy. Dr. Majid covered very well the extent of the problem. Obviously, everyone knows it's a global problem, more probably in the Anglosphere, but more and more we're seeing it even in Asian countries. And the numbers and percentage mentioned by Dr. Amjad in Iraq raise a lot of concern, actually, knowing that Iraq have a lot of poverty and have a wide scale unemployment, etc. So it is a global problem. Now in Australia, the latest numbers will clear 1 1/3 are obese, 2 1/3 or 2 out of any 3 person are either overweight or obese, and 1/4 of kids are overweight. And in a few years, it's expected that these figures will be much higher, that 83% of the males and 75% of females, and 1/3 of young people between 5 and 19 will be obese. So it is a huge problem. Now, I will stop a few seconds at the definition of obesity as chronic disease. At least from 2013, obesity is recognized as a disease, as a chronic disease, and at the base of the 3 leading chronic diseases. Now, the chronicity, it doesn't reflect the stage or doesn't reflect the duration of the time. It also indicates that we are dealing with a disease with no cure. And this had a lot of implication on the treatment of obesity. So there is no gold standard treatment or ultimate treatment for obesity, because regardless to the method of treatment, the problem is still there. Even surgery in all its form, it is not the ultimate treatment of obesity, because as I said, it is chronic disease, and without continuing lifestyle modification, exercise, etc., even surgery will have a limited outcome. Now, talking about the management of obesity, the therapeutic spectrum of obesity, starting with the lifestyle modification, diet, and exercise, it is a limited gain, limited loss in the total body weight, and this loss regained within the first year after this diet and exercise. Using the medical or drug therapy, even joined with the lifestyle modification, wouldn't achieve 10% of the total body weight loss. And again, it's regained once the medication stopped. And the problem with the medication, as Dr. Majid mentioned, the profile of side effect, which make them not possible to use them on long-term basis. So far, the surgery is the ultimate treatment, and obviously the outcome with surgery in its form is very good. So with the sleeve surgery, laparoscopic sleeve, we can have at least 25% of total body weight loss, and with the bypass surgery, with the Roux-en-Y bypass surgery, up to 30%. And this but is important, and I hope Dr. Muhannad wouldn't mind if I mention that surgery is of a high rate of morbidity. First, because we're dealing with obese patient with a BMI of more than 30, usually more than 40. And this by itself is a risk factor for any surgery. By the ASA grading, it is a risk factor. On top of that, obese people have other comorbidities, which make them at higher risk for operation. This is very important. The altered anatomy is as a concern that many people start to worry about. We don't know what happens. Sorry?
Dr. Ahmed, I'm sorry to interrupt, but there is some people, if they can mute themselves, please.
Yeah.
Okay, go ahead, please, Ibrahim.
Yeah. So the concern about altered anatomy, whether by sleeve resection or by bypass, is being addressed actually, and it's a worry. And we don't know actually that the progress and the outcome on long term after 10 or 20 years after these surgeries. For this reason, there was a good background to think of a procedure or a maneuver which can bridge the gap between a low risk with a very low benefit maneuvering or treatment, and the high outcome with the high risk of surgery. And this is the field of the endoscopic bariatric therapy. Now the promise with the bariatric endoscopic intervention is that we can get a reasonable weight reduction of more than 10% at a low risk, considering the limited complication margin there, and also with the lower requirement of resources, because the intervention can be done in a day surgery, for a day surgery procedure, without any need for any major equipment or hospitalization. Now, the real indication for the endoscopic bariatric therapy are three virtually. First, overweight people with a poorly controlled metabolic syndrome. And I will add to the number of components of this syndrome that Dr. Majid mentioned. He mentioned diabetes, hypertension, dyslipidemia, gout. We consider NASH, non-alcoholic steatohepatitis, or non-alcoholic fatty liver disease, as part of this metabolic syndrome with the root of insulin resistance. So there is a very good evidence that bariatric treatment can help metabolic syndrome and the NASH. The second category is patients who are unfit for medical reasons for bariatric surgery, or they are not willing to take the risk of bariatric surgery. The third category is cases which are at high risk for surgical intervention because of the comorbidity, and the endoscopic intervention is a bridging procedure to help reducing weight so that there is less risk of complication of anesthesia and surgery. When we talk about endoscopic bariatric therapy, we always talk about lifestyle interventions. In the good units of the endoscopic bariatric intervention or therapy, there is always a team of a dietitian with interest in obesity and weight loss. There is a exercise physiologist, not a physiotherapist, but exercise physiologist. And there is a psychologist with interest in obesity, plus a bariatric general practitioner. This is the team which run the show, with some follow-up by the consultant over a period extending between 12 and 18 months, depending on the package. Now, the mode of action, it is a combination for the endoscopic intervention. So we have either gastric procedure or small bowel procedures. I think the most important mode of action is the slowing gastric emptying that just induce a gastroparesis by restricting the volume of the stomach. And the third one by aspirating the content of the stomach. And I'll come to that later on. Now, in terms of the small bowel modalities, the promise is that these modalities affect the absorption, decrease the absorption of nutrients. But there is some hope that this might affect in the same time the metabolism and absorption of bile, and also changes related to the glucagon-like peptide 1, which play a major role in this part. And there is some sort of some reflection on the microbiome. And by the way, microbiome is now a very important area in places like Japan and China in dealing with obesity on long term as a chronic problem. And they are working on the first 100 days of pregnancy and manipulating the microbiome and the diet of the pregnant woman to deal with the obesity from the intrauterine life. Now, there are 5 types or modalities of endoscopic interventions: the space-occupying devices, the restrictive procedures, the bypass procedures, aspiration therapy, and others. And in fact, only few of these modalities are in practice with a good evidence. Now, the first one is the Intragastric Balloon. And the mechanism of Intragastric Balloon is mainly delayed gastric emptying and decrease the capacity of the stomach, particularly at the level of the fundus, because the requirement for deploying the balloon is to have it sited in the fundus, not in the antrum. And by this, it can decrease the capacity of the stomach. Now, one of the benefits of it is actually a behavioral. Now, over the period of 6 to 12 months of having the balloon, there is a punitive effect. So any overeating, any rapid eating, any poor choices of food will be punished, because there will be significant symptoms for all these. And the hope is, with the help of the psychologist, that these habits will be altered at the end of the course, which is between 1 year and 1.5 years, a combination of lifestyle modification and the effect of the balloon. Now, in summary, the adaptation period for the balloon early can be associated with nausea, vomiting, some colicky pain, some reflux, and some lethargy. But this should settle by day 5 with symptomatic treatment. And there is very, very delicate protocol for that. So there is IV hydration started from day 1 and continue in the infusion centers, and that will, in addition to symptomatic treatment. But any symptoms after week 1 it should raise alarm and concern, because these can be related either to the procedure itself, like for example the impaction of the balloon in the antrum, or the hyperinflation, so the size of the fluid or air is much bigger than expected, or the accumulation of food and secretion above the balloon. It can also relate to complications like peptic ulcer disease, or pancreatitis, or cholelithiasis, biliary colic, or cholecystitis. Now, the eligibility, patient above with a BMI of more than 25 who are less than 70 after eradicating H. pylori, and the contraindications. There are quite a few contraindications, by the way. So any type of previous surgery, any large hiatus hernia, any active peptic ulcer disease, any stricture of the esophagus, any vascular problems like varices or GAVE, which are the gastric antrum vascular ectasia, the watermelon stomach, all in addition to pregnancy are contraindications to the use. Now, we have two main intragastric balloons. The first one, which is the first chosen after a series of failure, is the Orbira. And this is a fixed volume with saline and methylene blue. It's used for 6 months, then removed endoscopically, and the expected weight is loss of about 12 to 15%. Now, the SPAT3 is the widely used balloon, and I'm inclined to this type of balloon. It is the third generation because SPAT2 and 1 failed, and it is the only adjustable balloon available in market right now, and this adjustability make it more flexible, so it can be increased when the weight loss is limited, and it can be decreased when there are significant symptoms there, and the weight loss is even marginally better, between 17 and 19%. It has a common side effect, which is the complication, which is the gastric ulceration. Now, there are other balloons that they are not widely used, the dual balloon and the triple balloon. This is the capsule balloon. A lot of people ask and wonder about it. The only benefit of it is that the introduction initially is not endoscopic. So the patient have the capsule swallowed, then the cover of the capsule disintegrated under the gastric acidity, and the balloon then inflated with the nitrogen gas, and then the connection is disconnected. Then that is in week 0, in week 4, and in week 8, this process is continued, and the patient ends having 3 balloons in the stomach. But ultimately, after 6 months of having it, the 3 balloons need to be removed endoscopically. There's not much extra benefit over SPAT or the Orbira. The transpyloric shuttle, there is a lot of talk about it. This is ensembled endoscopically and desampled endoscopically, and the range is the same. The Satisphere, this is an entinol backbone with the spheres and 2 pigtails. The promise is that it is slow the duodenal transit and decrease the absorption ultimately. Now, in terms of safety, both are safe, and the most common complication is the ulcer, which is more with the SPAT3, but with the treating the H. pylori and having the patient on double dose PPI and avoiding NSAID, this complication will be limited. People tolerate the SPATs more than Orbira. There is always a risk of migration, 1 in 500, or perforation, or even death, 1 in 10,000. Now, the second modality is restrictive procedures. And in restrictive procedures, it's about reshaping or remodeling the stomach by either suturing technique or stapling technique or tissue anchor. And the most widely used is the endoscopic sleeve gastroplasty, the ESG. This is the most widely used. It was introduced in 2012 in Mayo Clinic, but in fact, the pioneer of this procedure is Professor Lopez in Madrid, in Spain. I have my training with him. He introduced it, but then he went to Mayo Clinic to train them. But most of the numbers currently are under his name. This is based on using a special device attached to the scope through an over tube after introduction. And it's based on suturing at 6 layers or at 6 levels, the stomach starting from the angularis going up to the fundus, ending with a tubular shape, similar exactly to the surgical or laparoscopic sleeve, but sparing the fundus. And this is one of the differences between the endoscopic sleeve and laparoscopic, because to my knowledge, most of the time, the fundus is obliterated during the laparoscopic surgery, and that's why the high rate of reflux, which is untreatable reflux, in fact. But in this procedure, the fundus is spared, and there is no major reflux side effects or complications. Now, which people are eligible to have it? Those with a BMI of more than 30, and we mentioned the indications, but they are very strict. That's why screening gastroscopy earlier is very important. So the patient should have no family history of gastric cancer. He shouldn't have any intestinal metaplasia or atrophic gastritis, because there are precursors to gastric cancer. And if the patient is not having intestinal metaplasia, it's a cross. He shouldn't have it, because then there's no much way of screening. It's unlike the laparoscopic resection, where the part of the stomach is removed. Here, the part of the stomach is still there. It's also contraindicated until treatment of active ulceration, in multi-organ failure there, and also in pregnant women or lactating women. People on anticoagulation is not absolute contraindication. Now, the published data, we have now more data, but these are the ones which are published and available. It is anything between 14 and 16% in the first 6 months, and up to 20% in after 12 months. That's in conjunction with other lifestyle modification. And it's almost similar. Lopez in Spain and Shariha is in Mayo Clinic. These are the numbers. They are most likely comparable with each other. Now, I should mention that over the last 18 months, an IPC was introduced, the argon plasma coagulation, at the site of suturing, which increased the scarring and increased the stiffness, and then increase actually the transit time. That's increased the gastroparesis, which is the main target in this regard. The reported rate of complication is 1%, mostly related to collection, and this depends on the technique also. Collection around the stomach. I'll skip this for the predicting the outcome. Comparing the ESG with the surgery, both lap, sleeve, and the bypass. This study from 2018 compared the 3 modality, but not prospectively. That's why it's not a strong study, because there is no randomized controlled trial data from that. But 12 months with the retrospective cohort, the laparoscopic sleeve surgery is the most effective, followed by the endoscopic sleeve surgery, which is superior to the lap banding there. And if we talk about BMI between 30 and 40, not above 40, actually there is no statistically significant difference between the laparoscopic and the endoscopic surgery. اعتقد الدكتور مهند راح بعد شويه بحضر لنا حكي شوي على هذا الموضوع، بس هذا الموجود يعني. In terms of morbidities, the least is obviously the endoscopic sleeve. You can see the difference between more than 9 or around 9% and 2% there. And the inpatient stay, definitely it is superior to others. The idea is that the patient can have the procedure. By the way, it takes 45 minutes in a person after doing 50 procedure, and in a beginner it might take 1 to 1.5 hours. But that's the average of time. And the patient discharged on the same day with some antiemetics and with some analgesia. Now, the second form of the restrictive procedure is what they call it TOGA. This followed different technique by suction and stapling rather than suturing, but it ended with the similar concept of having tubular stomach. It's not available here in Australia, and the numbers even in the States and Europe is not huge. There are some other less advocate one there, including the pause, where they create folds with the aim of decreasing the capacity. There is also creating folds, but intermittent for the same purpose. Teres is virtually is a gastric band using the endoscope, and there's not much data, but it's small series, and I don't think it's widely used. Now, the third modality is the bypass devices, and these are the small bowel ones, and we have two main ones. The first one is the endo-barrier duodenojejunal bypass linear, where there is a 60 centimeters nickel titanium implant deployed endoscopically in the duodenum. Now, the hope is that this will affect the absorption, but in fact, the impact of this procedure on weight loss is limited, but it is very well recognized in controlling metabolic syndrome. So it is more for controlling metabolic syndrome rather than achieving good weight loss. The second bypass one is the gastroduodenojejunal bypass sleeve, and this is a joint work between the laparoscopic surgeon and the endoscopist, where there is 120 centimeters a sleeve fixed or anchored at the gastroesophageal junction by full thickness suture, where food pass through this sleeve, and they aim also decreasing the absorption. The fourth modality is the aspiration modality. I'm about to finish the procedure, and sorry for the delay. Now, the aspiration therapy, if you heard of the pig feeding or pedge feeding, the percutaneous endoscopic gastroplasty there, where we put a tube for feeding for people with a variety of indications: strokes, dysphagia, aspiration, facial-maxillary malignancies with radiotherapy treatment. We feed them at least temporarily through this tube, which we can extend it to the jejunum for better absorption. Now, the same idea, but the tube is connected to a device the patient can ensample, and then 20 minutes after his meal, he goes to anywhere, toilet, etc., and get rid of the content. And it is estimated that about 30% of the calorie taken during the meal will be discarded. The numbers indicate that up to 20 kilograms in the first year weight loss, and 23 kilograms in the second year. Now, the last modality is very, very well known, which is using the Botox in inducing delayed gastric emptying, and this is injecting 100 to 300 units of Botox at both the intrum and the fundus, with the hope that this will decrease the gastric emptying and also inhibit the ghrelin secretion. In the future, there are quite a few modalities, including using combination of these procedures. I'll stop here, and thank you very much for the opportunity.
Thank you very much, Dr. Ahmed. Very comprehensive talk. I think it's covered most of the catalyst techniques. So I think we still have one more presentation, and I will try my best to be as fast as possible once again. And I'm just trying to share that. Okay. Right. So in this quick talk, I'll try to skip this slide that have been explained in common with the other two colleagues, and it's all about weight loss surgery per se. I'm not trying to emphasize more on the indications as Dr. Majid mentioned them, but certainly a BMI from 30 to 35 in Australia will still see difficult to involve them, although sometimes we go a little bit over the guidelines, especially if the patients have comorbidities. So the contraindications, as mentioned, most of them have been mentioned by other colleagues. One of them, the pregnancy. Pregnancy is a contraindication to all treatment modalities, unfortunately. And
sorry, Dr. Mohanad. I think Dr. Ahmed is still presenting his slide. We cannot see your slides. So probably Dr. Ahmed stop sharing and no, yeah.
Can you confirm, Dr. Majid, can you see my slides? I can go back. It's only one slide.
Yeah, I can see it.
No, you can see it now? I see the slides of Dr. Ahmed is still there, the summary of the last slide of Dr. Ahmed. I think Dr. Ahmed should stop sharing now and you can.
Yeah, I stopped sharing. I stopped sharing, doctor.
Okay. Okay. Can you try again, Dr. Mohanad? I think you have to start.
Can you see my slide now at all?
Yep.
Yes,
yep.
now, yes.
Yes, okay.
Excellent.
All right, so
yes.
Just a quick repetition that the patient selection, Dr. Majid has spoken about them. The contraindications are sort of similar to the other contraindication in other categories. And just one note about cirrhosis. If it is compensated cirrhosis, actually it's indicated. We have received lots of referral from gastroenterologists to help with people morbid obesity with liver cirrhosis, especially with NASH. But of course, with uncompensated cirrhosis and portal hypertension, ascites, for example, in the abdomen, we cannot do the procedure. One of the common contraindications is mental impairment, because we need the patient coordination. We need the patient help with the project, we call it. Of course, the common severe medical conditions are one of the other contraindications as well. The preoperative review is comprehensive, and to work it easily from the audience that the weight loss surgeries are either gastric banding, a sleeve, or a bypass. The gastric band is done in rarity nowadays. So I stopped doing them for the last 9 years. Actually, perhaps every second week I remove one due to band complications. So the majority of our colleagues are not doing it. So we not talk about that today, but perhaps I'll show you some band complications. So is it a sleeve or a bypass that I'm going to do to my patient if he fits the criteria and there is no contraindications? The most major differentiation factor here is there any reflux or severe hiatus hernia? Because we all know that sleeve gastrectomy is reflexogenic. So I shouldn't give it to a patient with established moderately severe to gastroesophageal reflux with hiatus hernia. Bypass is the way to go, and I'll explain that a little bit more as well. So we always do a CT scan, and if they have reflux, then we always do gastroscopy as a preoperatively. And if I can demonstrate reflux esophagitis, for example, with some ulcers, large hiatus hernia, a sleeve is not an option anymore. Although they lose weight, but that will only make the reflux worse. A bypass is then the way to go. And a variety of blood tests, etc. And of course, I give them a detailed dietary advice during the same primary consult, and I see them again in a few weeks' time before the operation to see if all of their investigations are good, no reflux, etc. And if they're keen for a sleeve gastrectomy, then they go for a sleeve gastrectomy. What if they don't have reflux and they're keen for a bypass? Then this is patient selection. We tell them you can have either or, and we tell them the pros and cons of those two operations, and they will share the decision as their wish is highly respected too. And we do like some 2 to 4 weeks of weight loss when we put them on shakes preoperatively. And we do believe in the protein sandwich hypothesis. It is not a protein sandwich that we give the patient, but basically we give them a shake in the morning, a shake in the evening of high protein, low sugar drinks or soup. And we give them a natural meal each time, which is a natural meal is a large piece of meat with some fat and some veggies, no carbohydrate. And a large piece of meat is defined as a piece of meat that is visible from a distance. It has to be large. It has to help them to get full so they can survive the 2 to 4 weeks without becoming malnourished or severely starving. The preoperative optimization, once again, we spoke about GORD. A good number of them come with gallstones. And once it's better to be dealt with before we start the project, i.e. if they have symptoms, it's so easy to offer them a laparoscopic cholecystectomy, even in their very high BMI, and remove the gallbladder and take it from there. And of course, contraceptive will need to stop, smoking need to stop for 8 weeks, etc. Before we start. Sleeve gastrectomy is the commonest, and it's associated with some good 70% of excess weight loss. I will get the video going so for you to see, and I'll keep on talking. It's a very short video. So that is a sleeve gastrectomy. Basically, it's a restrictive procedure. In this, we try to cut the stomach very small to make it look like a sleeve. So basically here that we have mobilized all the greater curvature of the stomach from the pylorus all the way up to the gastroesophageal junction. And here, as you can see, the bougie was inserted by the anesthetist, and it's 36 French, so it's only 12 millimeter. And this is my stapler. We staple all the way against the bougie to give the result of a short, narrow sleeve that goes from the antrum of the stomach all the way to the. And yes, as Dr. Ahmed mentioned, we don't spare the fundus. We can't do that because that has been associated with bad effect. And we know that most of the ghrelin hormone is located in the fundus. We're very keen to remove it. And the final step here, that the stapled end side of the stomach is sutured again to the omentum to provide some stability and to prevent the rotation of the gastric sleeve, a procedure that we finish in some 45-60 minutes, and a patient will stay in hospital for some 2 days. And so I might stop the video. There's nothing more important after that. And then the patients stay 2 days. We see them. We do have some very specialized bariatric dietitian that we trained specifically to deal with bariatric patients. And they give the patients simply a fluidy diet for 10 days, puree diet for another 10 days, and then soft diet for a third 10 days. At the 4 weeks to 6 weeks mark, they're usually able to eat not soft diet. The capacity of the sleeve stomach is something like a can of a Coke in total. So if you imagine a can of a Coke, you need to divide it in 3/3, 1/3 for solid, 1/3 for liquid, and you would still leave 1/3 for gas. So i.e., they cannot eat much at all to fill the sleeved stomach. So it's truly a restrictive procedure. Not only that, the gastric sleeve as well would provide a fast transit. So whatever they eat, it would go all the way down to the mid-small intestine. And here the hind gut theory applies in a way that we believe the sleeve gastrectomy also induce early satiety, as a very hypertonic, full of calories fluid would reach the mid to distal small bowel relatively faster compared to normal people. Bypass on the other side. I'll get the video going as we will save on time. There's two types, either a single loop or the classical Roux-en-Y. So here in that movie, this is a Roux-en-Y where the surgeon is actually cutting the small intestine some 50 centimeter from the ligaments of Treitz, which is the duodenojejunal junction. And then immediately after that, we calculate, we call it a biliary limb of something like 1.5 meters to join it with the cut end of the intestine is the enteroenterostomy. So here what we created a bypass of 1.5 meters to 2 meters at least entirely of the resorptive surface of the upper and middle small intestine. That's why it's a malabsorptive procedure. Not only it's a malabsorptive, but also a restrictive, as you would see in the video, that the stomach itself is reduced to a very small pouch. And if the sleeve gastrectomy is the size of a Coke, the pouch of a bypass, which is now we're cutting it, now it's something like only 6-7 centimeters from the gastroesophageal junction. So this pouch would perhaps fill in some 100, perhaps 250 mils. So it's such a small pouch in addition to malabsorptive, that this is a combined restrictive and malabsorptive procedure. Of course, then by definition is associated with a significantly high rate of success compared to sleeve. So if the sleeve helps us to lose some 70 to 80% of excess body weight at 12 months mark, the bypass perhaps would approach 90. Effect on diabetes, much better on a bypass compared to sleeve. Therefore, if patient is morbidly obese, super morbidly with severe diabetes, perhaps a bypass is the way to go. If the patient is with a reflux, as I mentioned, a Roux-en-Y, the way that we're doing it, bypass is the way to go, because by itself is a treatment for a reflux, as you remember. If we have even a non-obese person with a refractory reflux, then a bypass is the way to go. How about a single loop bypass? If the patient is super morbidly obese, but does not have a severe reflux, then a single loop, just a loop which is 1.5 to 2 meters of the small intestine will be raised, and it's the same pouch that we mentioned, and we join it. The win in that we're doing a one joint less, so we don't have to do enteroenterostomy. It is a loop that goes up to a prepared pouch of the stomach, the way I showed you. Why are we doing single loop? It has been associated with the same rate of weight loss. However, if your patient is in reflux, then a Roux-en-Y bypass is the way to go. What if the patient develop reflux after a loop? Then we have to convert them to a conventional Roux-en-Y bypass. Recovery, once again, usually 3 to 4 days, sometimes even 2 days in hospital. High-risk patient, very high weight, we send them to the ICU. Mortality is not high at all, and it is sort of 0.2 to 2%. The immediate complication is basically leak and sepsis, and often those people leave the hospital and come back on day 7, 8 with fever and pain, and a CT scan would show fluid. I'm coming to that very soon. And the monitoring goal, I usually see them as part of the project every 6 weeks for at least a year, and give them significant coaching in everything, including dietetics and exercises, etc. And with the help of our GPs, general nutritional blood tests will be repeated every 3 to 4 months during the program. Once again, multivitamin has to be given every day, because that is the norm, and the gym is allowed at around 6 weeks mark. The short-term complications, the main one of them is the leak and sepsis. As I said, we investigate them when they present back with fever and abdominal pain to find a leak either from the sleeve staple line or from the gastrolegionostomy anastomosis, in which case we either treat it endoscopically with the help of the gastroenterology department by inserting an internal stent, or laparoscopically by doing a washout. Sometimes we need to revise the anastomosis, but that is exceedingly rare. Bleeding is another complication. Fortunately, it is very rare. I remember in all of my cohort, one patient 4 years ago bled. The problem with the bleeding, that is, it gives you very minimal abdominal signs. They're super morbid obese. They don't show any tenderness. They show tiredness, low hemoglobin, and tachycardia. Most of the bleeding is intraperitoneal, not intragastric. If it is intragastric, they usually show you in hospital like a hematemesis, as we all know. The treatment to that, we have to take them, we have to rush them back to theater, and often you find it immediately and fix it, and that's proven not to affect the length of stay if you fix it well. Small bowel obstruction is not uncommon, especially in people with Roux-en-Y gastric bypass, mainly from internal hernias. That's why the teaching that any patient with bariatric surgery who comes with pain, we need to exclude three things. Is it gallstones? Is it peptic ulcer disease? Is it an internal hernia? Unfortunately, the CT scan is not sensitive at all to show internal hernia. So if they call me from the emergency, a patient abdominal pain, post Roux-en-Y, I feel very easy to offer them a diagnostic laparoscopy. We often see the hernia reduce it and close the internal defect. And if that is not diagnosed promptly, then a risk of ischemic gut is very high, and we have seen that in practice too. So a weight regain and a failure to lose weight, once again, is not common at all, especially if there is no patient factor. Cause of that is either error in the technique, for example, a very generous sleeve, very wide over a large patch of gastric bypass, or a patient factors. People lose interest, start eating the wrong food that they are forbidden, and of course, then they plateau their weight and they gain weight. What is the approach here? We fully investigate, including CT scan, barium solar, and gastroscopy, especially 3D CT scan, to see how much stomach and how it's working, etc. And if it is a sleeve and they lost weight, then a bypass is the way to go, as I mentioned. So as a consideration of another weight loss. Stricture is more common in bypass than a sleeve. Once again, it's in general not common, mainly from an ulcer that was as a marginal ulcer, the gastrointestinal anastomosis, and often respond to, after we diagnose it and we exclude all other possibilities, it responds to dilatation as a first-line therapy. But if that is not responsive, then a laparoscopic revision, and we sort of revise the whole anastomosis to make it very wide. Once again, gallstones and ulcers, as I mentioned, any pain in those post-operative patients, especially when they approach our GPs, the teaching nowadays that it is either stones or an ulcer at the anastomosis or an internal hernia. So in all patients should have an urgent ultrasound and an urgent referral to the surgeons to perform an endoscopy, plus minus diagnostic laparoscopy in case of bypass to exclude internal hernia. That's the only way. That's the only way. So if we on call, we take them to theater the same evening. We do not wait until next morning to establish the cause of their abdominal pain with a background of hernia. Reflux is more after a sleeve. The treatment to that is either if they associate with a small hiatus hernia, take them to theater to fix their hiatus hernia and preserve their sleeve if they have done good weight loss and see how they go. That might help. But if they have tremendous severe reflux not responding, then unfortunately a revision to Roux-en-Y gastric bypass is the way to go. If they develop a reflux with mini bypass, then once again, a Roux-en-Y gastric bypass is the way to go. Internal hernia, as I said, it is a prompt, urgent laparoscopy. I don't mind 10 negative laparoscopies, then missing an internal hernia with gangrenous bowels. Band complications, I see it become more frequent. This is one of my patients, actually not mine, I was on call. A patient had a band 20 years ago, all of a sudden came with vomiting and severe peritonitic abdomen, and a CT showed the problem, took him to theater, and that is the band. And what is above the band is with the upper third of the stomach about to die. So we removed the band immediately. Patients showed remarkable improvement. As a management, we settled them over 3 months, and we talked about another weight loss surgery if they like it and if they qualify. Rule of thumb and a take-home message: it should be a bypass upper band, not a sleeve, because the band has ruined the COJ, given already the patient some reflux, and you want to do a sleeve, which is a refluxogenic operation. This does not coincide with the teaching. So the best way to do it here from a band is a bypass operation. Dumping, I might leave the dumping. I'm very happy to talk to it in the questions. And That is my last slide finally. So we do see success. Yes, it has some morbidities, but not common at all. At least 80% of excess weight loss. Careful monitoring and coaching of the patient for 1 to 2 years is of paramount importance to achieve excellent results. Sleep apnea, hypertension, metabolic syndrome, very high rate of resolution. Thank you very much, and I apologize once again for the late finishing. Thank you.
Very good. Thanks, Dr. Mohammed. Thank you very much.
Thank you. Thank you very much. We try to see if there's any questions.
And I have 2 questions. One is directed to Dr. Majid. Dr. Majid, you mentioned some numbers about Iraq. Is there any institute, or these are local numbers? And that's one question. The second question is about the availability of surgical and endoscopic bariatric treatment, at least in Basra.
Yeah, thank you, Dr. Ahmed, for these couple of questions. Regarding the first question, the number that I've shown you is from the WHO stepwise survey that was conducted 11 years ago. We don't have the recent numbers. Actually, these are old numbers done by the WHO. That survey involved more than one governorate from Baghdad, from the north and from the south. Regarding the second question, yes, we do have both of the endoscopic procedures and the bariatric surgery procedure. In Basra, for example, in collaboration with the American Society of Bariatric Surgery, we opened a center for bariatric surgery, a training center that we give a certificate after a couple of years of studying a subspecialty of bariatric surgery. Myself, I'm involved in teaching in this center as an endocrinologist, and we have the subspecialty now in gastroenterology. They do the endoscopic procedure that you talked about nicely in your presentation.
Excellent. Dr. Mohammed?
Naam, Dr.
If there's no other question, can I ask you a question?
Go ahead, please.
What after bypass? What after the Roux-en-Y failure?
Yeah, so in Australia, we do have some other procedures. I did not mention them for the sake of the time, but we do have the procedures as like a duodenal switch. So in addition to the bypass, we sort of removed all the antrum and tried to do a double switch to bypass more of the small intestine. It's proven better in terms of failure of a Roux-en-Y gastric bypass. The rule of thumb here, the take-home message, a patient who has failed a sleeve and tried the best and failed a gastric bypass, and the absence of technical factors or patient factors would perhaps unlikely to benefit from repeated more complicated weight loss operations. But it has been done, it is done in Australia. And once again, Dr. Ahmed, it has originated all from Spain. It all came from Spain. So we do have those. We do that in selected patients and in selected centers because we prefer that a single group of surgeons to deal with those complicated bariatric procedures. Yes, Dr. Majid, if you can unmute. Actually, the other Majid, not Dr. Majid Al-Aboud. I asked Dr. Majid to unmute. If you can, I can. Yes. Dr. Majid, can you unmute yourself if you have a question? Or anyone can either write the question down or raise hands. I should think we allow some 5 to 10 minutes to questions before we conclude.
Dr. Mohammed, if there is no question, can I ask a question, please?
Go ahead, please.
Yeah. So the major issue here with the bariatric surgery in Basra and in Iraq in general it is not subsidized by the government. I mean, it is totally done on a private basis. Even in the public hospital, the patient has to buy the stabler and the other things. I don't know the names, but it costs around $5,000 American dollars here in Basra. But what about the story in Australia? Is it totally subsidized by the government, or?
It is, sure. Thanks for that, Dr. Majid. It is not subsidized at all by the government. It is basically a procedure that is done in private hospitals. And sure, you can divide those people into two categories. People who are health insured, and if they have the right coverage of health insurance, then that will cover a small portion of the cost of the bariatric surgery, but luckily that will cover the whole hospital cost, which is the majority, and still the patient has to pay a portion to the surgeon and the anesthetist. Inclusive in that payment is a free follow-up for at least a year. If the patient is not insured, it would be very keen to include the follow-up, because so at least we can see our patients. I don't want any financial conflict from patient to see me on second or third month as if I'm after the final results to help them lose weight. If the patient is not insured, then usually the cost, overall cost, is something like 17 Australian thousands, because the hospital itself charges some 12.
Yeah.
So I think the patient only has to pay $5,000 American dollars in Basra. I think I see it as still a good price, and I'm sure we have excellent colleagues there who can do the procedure neatly. So I think that is still good, but we're not different. We perhaps worse here.
Yeah. Thank you.
I think Dr. Majid is with us. Dr. Majid, go ahead, please.
اولا شكرا جزيلا لاستضافتكم لنا، والشيء الثاني ممنون من المحاضره القيمه اللي استفادينا منها كثير، رغم قسم من عندها تهم الجراحين اكثر من عندنا.
نعم.
بس سؤالين عندي.
تفضل.
اعتقد دكتور مهند او دكتور ماجد العبود تطرق لها. السؤال الاول حول الكاو ميلك. أنا قرأت في إحدى المواضيع أو الويب سايتات بالنسبة للبحوث اللي طرحت في سويسرا، كان فريقين، فريق ضد فريق. فريق قال إنه الكاو ميلك كلش غير مفيد وكذا وكذا وكذا، هاي السايد إفكت مالته مهم. والفريق الثاني لا، فند هاي الفريق الأول قال لا، هم أجروا تجاربهم على فئة معينة، واحنا وجدنا انه هاي اكو غير فئات لا استفادوا من عندها. بس سؤالي هنا اولا مدى صحه هاي البحوث، والشيء الثاني اي عمر which age يعني يترك واحد شرب الحليب. هاي شكرا، هاي سؤال اول. والسؤال الثاني الدكتور احمد ربعي من بعدين مع الشكر.
لا بأس، لا بأس. بالنسبه لسؤالك عن الكاوميك انا تطرقت الى يعني هو انت شو what are the side effects of a cow milk? Actually there are two. A, the sugar, and B, the protein in the milk itself is more allergenic. So can I just leave this meeting and go and take a cow milk? Of course I can. Nothing generally will happen if I am not lactose intolerant. But we're talking here that the sugar content of the cow milk is very high. That's why it's meant to feed the cow babies, so to inflate them. And by and large, the easiest way on the planet to increase weight is to drink milk. And the most effective way to increase weight is to drink milk. That's why إذا تروح للخدج تشوف إنه هو يجي وزنه كيلو ورا أسبوعين يصير وزنه كل زين because of the milk, of the bottled milk. So basically, if you want to inflate somebody, give him the milk. That's why we feel in bariatrics world, this is actually working totally against us. Because I need to ask the person a question: why are you really drinking the milk? Do you think it's healthy? Or it's just a habit? If it is a habit, then please stop this habit, because the milk is giving you a loss of sugar that you do not need. If you think this is healthy, I argue with you, because the health is, if you think you need the protein and fat, go and eat cheese. If you think the calcium is the same calcium that the bacteria left for you in the cheese, but the bacteria has done you a favor by removing all the sugar from the milk and changing the protein structure in the milk to make it less allergenic to you. And I see endless number of my patients, they come to me with lactose intolerance. When I ask them to eat the cheese, they feel okay. And they always say it's only the coffee, the milk and the coffee that make us lactose intolerant, give them the crampy pain. So I don't believe at all that the milk is good actually for adult people. Can a slim adult person utilize milk? Once again, why? Is that, are you keen to take more sugar? Even for a slim person, sugar is not good, because sugar increases insulin resistance. Even in a slim person, they might have a little belly with an insulin resistance, which is the majority of us. But what is the best age? I think we can perhaps accept it to our kids. But once they reach high teenage, I'll try to teach them that milk is not for you anymore. You can have a cheese, like a Greek salad type of cheese. You can have chicken Caesar salad. You can have any salad with a cheese in, but do not eat the bread, not good for you, and do not drink the milk. That is, once again, not good for your body. So that is my, so it is not a toxin, but it's really harmful in terms of your hemodynamics, especially if you are overweight.
Okay, thank you very much, Doctor. Thank you very much.
Pleasure. My pleasure. We have another question to Dr. أحمد ربيعي أعتقد.
Yes, please.
Go ahead.
بالنسبة للبالون بالون surgery, is any side effect against the immune system because it's foreign body? Dr. Ahmed Rubai?
Yeah. No, there is nothing to do with the immune system or with the hemostatic system or with any system. It is a foreign body, but it is in the lumen. It's not in the blood, and there is no reaction to this foreign body. So it is not absorbed. It's not part of the circulation. That's why there is no effect on the immune system or on any system. Yeah, and by the way, for Dr. Amjad, even the endoscopic bariatric intervention, all are not covered by the Medicare here, and it's all private, not even covered by the health fund. Yeah. أكو سؤال دكتور العفو.
شكرا دكتور ماجد. دكتورة Bushra has a question, but can you unmute, please? I sent. Okay, go ahead, Dr. Bushra.
Hello, marhaba. Thank you very much for the very, very useful information. It's a gush of information, you know. My question is to Dr. Ahmed. He was talking about the endoscopic bariatric surgery. And I just don't know, when it started in Australia and how often, and what's the success rate in his procedures. I have seen a friend in England last year when I went before Corona, and he did the endoscopic bariatric surgery. He is a doctor himself, and he lost about 25 kilos. He had very severe complication after the surgery, like vomiting, and he was on IV fluids, but then he was fine, and it was removed after 6 months. So what's the situation here in Sydney? I don't know. I didn't ask Dr. Ahmed before.
Yep.
So I just want to know an idea of simple statistic. Thank you.
Yep. Doctora, for intragastric balloon, it is more than 20 years since it was introduced. But the first few generation of the intragastric balloons were both physically and chemically not very compatible, and they were associated with more of the side effects or complications to their presence there. But the new generation, which started with the Orbira, it is now more than 10 years spots, it's around 8 years when they started. They are well modified, both in terms of the adjustability for spots, both in terms of the size for orbita, that the complications are minimal. There's no major complications. In fact, this vomiting is expected because this is a foreign body entering the stomach, and it is something sitting in the stomach. So nausea is expected, vomiting is expected, some pain is expected. The rate of more serious complication is very minimal, very minimal. When we talk about a peptic ulcer disease, it is less than 5%, but this is only in people with H. pylori, or there was no good follow-up, because for the spots, the follow-up include reviewing the size of the balloon and adjusting the size so there'd be less pressure. Now, the bad position sometimes affect the development of ulcer, because the balloon should be sitting in the fundus rather than in the antrum. And when it's in the antrum, it can cause pressure ulcers, and in the presence of H. pylori, this is promoted. So there's no major side effects, but vomiting is expected. That's why the patient come to the infusion center the next day, even if Saturday, and he is null by mouth, he or she null by mouth to have infusion, and the infusion continued for the first 2 days. And with this very stringent protocol, the margin of side effects or complication is very minimal. Now, the success, as I said, it is definitely inferior to the surgical, but with much less complications. And it is not designed for a BMI of more than 40 in all cases, unless the patient is unfit completely for surgery. It is designed for overweight, so BMI between 27 and 30, and obesity with the BMI up to 40. This is the design of it. Now, the current rate is approaching 20%. So I said the sleeve reduced 25% from the whole body weight, not from the excess weight. This is now 20 for the current gastric sleeve by endoscopy. So it is reasonable and it is impressive, but obviously a lot of modification need to be there to achieve the same level as surgery. Yeah, thank you.
Thank you.
Any more questions?
It's 10 o'clock now.
إذا ما
there's more.
الدكتور قبل لا تغلق عندي بس نداء دكتور أمجد. دكتور أمجد عزيزي، احنا يعني تواقين أن نبقي أو نمتن هاي العلاقة لأغراض عديدة، واحدة من عندها أنه هذا التواصل يفيدكم، يعني بالنهاية يفيدكم، وإحنا أيضا يصير عندنا فكرة عن الحاجات اللي موجودة هناك. فيعني هاي دعوة أنه أنت هسه ضمن الجروب مالت الأيام، فرجاء أي نشاط لكم، أي اكتيفيتي، أي ويبنارز، أي كورسات خليها عندنا، وبنفس الوقت إذا تصير بدون زحمة وبتفضل توسع دائرة الويبنارز والنشاطات مالتنا. احنا نطمح ان يكون في كل ويبنار زميل عراقي سواء من البصره او من غير البصره. فلهذا اتمنى ان يصير تنسيق وياك انت او من خلالك، باعتبارك انت ربع استرالي دكتور، انت جيت هنا اخذت اختصاص من استراليا.
صحيح.
زين. فعن طريقك يصير تنسيق ويا زملائنا، مثلا عندنا ويبنر باليورولوجي، احنا يهمنا ان يكون عندنا زميل. الغرض من عنده ان يعني we promote their achievements، وبنفس الوقت يصير عندنا فكرة where they are back with their progress. نعم.
أنا حاضر ولي الشرف أنه تكون حلقة وصل إن شاء الله، وبالتأكيد راح أدعو جميع زملائي، ودائما إن شاء الله يكون تعاون مشترك. هذا الشيء يسعدني.
ممنونين دكتور.
تسلم. شكرا جزيلا للكل.
شكرا جزيلا. Thank you very much. I think that is a time perhaps to close, and I thank everyone
شكرا جزيلا. شكرا دكتور مهند.
عاش في ايدك عيني. شكرا. تصبحون على خير.
مع
السلامه.
شكرا جزيلا.
شكرا جزيلا لكم. مع السلامه.
Awesome.